bearing on the subject matter of the program. Dr. Michael Jaffe has disclosed that he has no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. So Dr. Michael Jaffe was a physical medicine and rehabilitation and pain management physician at Kaiser San Diego for 21 years. During his tenure at Kaiser, he developed and ran the Department of Pain Management at Kaiser San Diego for the past 6 years. He ran several clinics, including the Spasticity Clinic, Amputee Clinic, Botulinum Toxin Clinic for musculoskeletal disorders, and the Low Back Pain Clinic. He is an associate clinical professor at Western University of Health Sciences School of Osteopathic Medicine. Dr. Jaffe is the author of the book Play Golf Forever, Treating Low Back Pain and Improving Your Golf Stroke Through Fitness. Dr. Jaffe moved to Hawaii in January 2018 and opened a private practice called Hawaii Brain and Spine. Please help me welcome Dr. Jaffe.
Thank you for inviting me to speak today. I really appreciate it. I guess there's some people that may be calling in, so I'm going to put this microphone on. And no reverb. Okay, great. So today's talk is going to be about opiates, what's going on at the federal level, what's going on at the state level, what's going on with different insurance plans, and what's kind of going on the windward side of the island and the leeward side. I know they always tell me, just talk for 10 minutes, but I always talk for at least 30, so just brace yourself. But I also want to leave it kind of open. If you have clinical questions or anything, just raise your hand and stand up, catch my attention. I'll try to answer them the best I can. First of all, what are opiates? They're ubiquitously found among our society. There's a bit of a distinction, and natural occurring opiates actually come from the opium plant. And that would be morphine and codeine, okay, as the basis. We use morphine as kind of the base to compare other strengths than opiates. What are short-acting opiates? And I know when I was going to medical school, they never really gave us a good talk on what are the opiates, how do they work, what's their pharmacokinetics, and it's so important. So I always like to talk to my medical students and give them a quick primer on what's out there. So codeine is still a Schedule III drug, which means it's one you can actually call in or fax in. The rest are Schedule II drug. The most commonly used opiate in the United States is indeed hydrocodone, followed by oxycodone, morphine, hydromorphone dilaudid. This is usually what we're using in ERs as a short-acting, rapid-onset opiate. Oxymorphone, it actually has some utilization, I think, in the Department of Geriatrics. It's one of the opiates that doesn't have a lot of metabolism to the cytochrome 450 system. And so for elderly patients that may have problems with that, it's almost one of the safer drugs to use. It doesn't build up as quickly in the system. And of course, tramadol, also a Schedule III drug that is used for pain management. It's got a very low dose equivalent compared to morphine, but it has serotonin in it, so you have to be a little careful with this medication if they're already on an SSRI or an SNRI, that you're not overloading them with serotonin. The long-acting opiates, we've heard of MS-Contin, kind of standard. OxyContin, we've heard a lot about. So Hydro is a long-acting Vicodin-type drug. I'm a little dubious about that one. It's got a high addiction potential. Methadone is long-acting. It has about a 36-hour half-life, but it only has a 4 to 6 hour pain management analgesias. You have to be very careful with methadone, especially the elderly population with renal and hepatic compromise. They can build up in the system quickly, so be very careful with the use of methadone. Fentanyl patch and buprenorphine patch, one of the newer kids on the block that you dose every 7 days. Excuse me? Okay, good. All right, so why are opiates so dangerous? Well, first of all, we know that opiates can be very effective for pain control in many situations. What happens, however, is that there's some bad side effects with addiction, and it's become the #1 cause of death in this country for people under the age of 50. So it's really become a nationwide health epidemic, an emergency, really. We'll see higher numbers than 50,000 for 2018, once that's correlated, probably closer to 70,000 people dying of overdose from opiates. Okay, so how did the opiate epidemic start? Well, for those of you who were at least in my age bracket, in the mid-1990s, there was this big push by JCO to make pain the fifth vital sign. Okay, so we're all scrambling to add that visual analog scale, numeric pain scale to our charting, right up there with blood pressure and temperature. The problem is we didn't know how to treat it. We just threw opiates at it. We had no guidelines. We had no guidance. And this led to very lenient prescribing practices for opiates. And I remember in the 90s, we used to think that people who started on opiates, there was only a 1 to 4% chance of addiction developing. Well, we know it's much closer, 25, 28% of the time. Someone who started opiates develops a substance use disorder. That's just a lot of people. So opiates for acute pain, again, very effective. Post-operative prescriptions, this is really eye-opening statistics, that if you give someone just one more prescription after an operation, so you give them one refill, it's 50% chance greater becoming opiate dependent and developing a substance use disorder. Very sobering. And there's a 20% increase for every prescription you refill thereafter. So again, we have to be very careful on these patients that we start on opiates with good intentions and then it just kind of spirals out of control. So there's very little literature on the use of opiates for chronic pain. Studies for chronic, a lot of those studies for chronic pain, if you look, have backing from the pharmaceutical companies. And the studies that are out there really don't show a lot of good analgesia for especially chronic pain conditions, 20, 30%. Of course, so many of our patients come to us with expectations of being pain-free, unreasonable as that may be. So I often have that discussion with my patients saying, look, I want you to expect 20 or 30% improvement by the use of these agents. There's a lot of other things we're going to need to do and you'll need to do with self-directed care to help work with that other 70 to 80% of pain management. But again, I think setting patient expectations is a very helpful neurotherapeutic approach when we treat patients for chronic pain. Okay? There's also no ceiling doses. So we as clinicians in the 90s, if they kept hurting, calling in, we just kept ramping up the doses. And when I started running the pain management department at Kaiser, we had some patients on 1,500 milligrams a day, 55 pills a day, like things that just really had spiraled out of control. A lot of them due to philosophical differences between the clinicians, I might add. So we know when we're dealing with the long-term opiates that there's some of these side effects, okay? We know it lowers testosterone levels. I had a guy I was treating today, severe peripheral neuropathy after chemotherapy for colon cancer. He was on methadone and he was on morphine. And he's a guy in his 40s, came to me, and his testosterone level's about 110. And I'd really like to bring it up, but I don't want to just give him testosterone because then he's going to be committed for life. I'm really trying to lower his opiate dose and increase his exercise so we can have more endogenous testosterone. So it's a big issue. They say up to 80% of men who are on long-term opiate therapy have low testosterone levels. And let me tell you, if you're a guy in your 50s and, you got a low testosterone level, you're a little overweight, a little hypertension, you feel crappy. So, I'm really trying to get these guys to, as men, increase our T levels, again, endogenous levels to help them feel better. There's increased fracture risk, increased falls, opiate-induced hyperalgesia. We really don't know what percentage of this is. It's probably maybe around 10%. But I can tell you, for our high opiate utilizers, that are high dose for a decade or so, 90% of these patients feel better when we get them off the opiates. 90% of these patients feel better when we get them off their opiates and on other ways to control their pain. Of course, opiate use disorder, and there's something we always have to be aware of, something called chemical coping. And these are patients that are using their opiates to cope with their emotional problems, to cope because they don't feel well, because they're sad, because they don't like their life. Okay, and there's a lot of chemical coping out there. We have to keep our eyes open for this and get more appropriate treatment. Okay, in a lot of my chronic pain talks, we talk about neuroplasticity, how our brain and our nervous system adapts to the challenges. Okay, this happens over time. Unfortunately, with chronic pain, there's changes in areas of the brain, such as the medial prefrontal cortex. And these are areas of the brain that help us make cognitive decisions about life choices. And for patients who've had chronic pain, for patients who are on chronic opiate therapy, the areas of the brain actually change to the point where they're making poor life choices. They don't exercise, avoiding healthy lifestyle changes, inability to get the body back on the correct course. So here's an area where I spend a lot of time coaching my patients, empowering our patients to really take care of their own health, to exercise, to eat well, to stop smoking, to don't abuse themselves anymore, to think positively. Lecturing upstairs at the Department of Geriatrics, I wanted to just show 2 quick slides about how this neuroplasticity may manifest in our clinics. That when patients come into us with a whole litany of other problems, fear and anxiety, persistent pain, they don't like their job, they don't like their spouse, they don't like their children, they're not happy people. This really helps, this kind of changes the way they are going to experience pain. Let's say we have a patient who's had a chronic low back pain, had a prior back surgery, and it failed. Now this is someone that comes to your office, they have a very different view of pain in their life than, let's say, I call the 2 jokers on the left, who are triathletes, okay? If these identical patients have sprained ankles, you can see the guys on the left, they're like, okay, I got a sprained ankle, I'm gonna adjust my exercise program, I got a race coming up in 8 weeks, so I'm gonna train for that, I'm gonna get better, and that's that, and they do. But you take the patient on the left, who is, has a lot of life problems, failed back surgery syndrome, maybe he's been taking long-term opiates, she may sprain her ankle, and she's gonna have a very different, the neurotherapeutics in her mind might be thinking more of setting her up for chronic pain, chronic disability, more anxiety, more depression. Okay, so we really have to sum up our patients when they walk in the door. Is this someone that's even a good idea to start on short-term opiates? Because they're going to be much higher risk of not getting off them. So some definitions. I think also working, one of the differences I find working with the geriatric population, if anything, they seem more afraid of taking opiates than anything. Okay, I usually have trouble convincing them it's okay, you can take that half a Vicodin in a day, you're going to be fine, I promise. Let's get you off that 800 Motrin 3 times a day, okay? And so I think having some helpful definitions help patients a lot. Opiate dependency is a normal physiologic response. It just means you're going to withdraw if we stop it all at once. And that's okay, that's expected. Opiate tolerance, again, also expected. Patients have reduced benefit from the drug when they've been taking it for a long time. I think the important thing is for patients to understand the difference between becoming dependent, which is okay, and addiction, which is another diagnosis, okay? Compulsive use of opiate despite bad consequences. In today's day and age, we're trying to shy away from using the word addiction in our charting and using substance use disorder. It has less of a stigma, and that may help influence the way they're going to be treated by their friends or family, the local pharmacists, and other clinicians. Okay, so we're trying to use substance use disorder instead of the word addiction. I wanted to go over very quickly, there were big changes last year, July 2018, in how Hawaii's opiate prescribing practices occur here. First of all, I always mention, if your DEA registration, your Narcotic Enforcement Agency registration goes delinquent and you write a prescription for opiates, you go straight to jail, they'll collect $200. This, I know it sounds pretty trite, but this happened to me in November. I just got a quick little email that, oh, my, Narcotic Enforcement Division prescription needed to be reviewed for 15 minutes. I'm like, yeah. Got onto my other emails, and I swear, a week later, I'm like, wait a minute, I forgot to answer that. So I went back and got it taken care of. But sometimes it can slip by us, so just try to stay on top of it, okay? Number 2 is, this has been a big change, is that pharmacists have a corresponding responsibility. So if I write an opiate prescription, the pharmacist filling that prescription is equally liable for any misuse, bad outcomes, or even overdose and death. So their feelers are way up, okay? And the problem is they don't have the patient, they don't have your chart in front of you, and so they've just got this piece of paper that you've written, and you spell one word wrong, and they bounce it back at you. So we have to be very careful because our pharmacists are really putting up their defenses to help this corresponding liability. The other thing is no more than the 30-day supply of opiates. This is very smart. This is one of the smart laws that Hawaii has laid down, and a lot of the insurance companies are also following this. They won't allow our patients to fill sooner than 30 days, which, by the way, can be very helpful. Opiate written policies, not only are they talking about patient agreements, but actually if you're writing for opiates, especially if you're dispensing opiates from your office, you need to have a written policy in your lock vault somewhere so that if you were ever evaluated by the Drug Enforcement Agency, you can say, well, this is our policy for writing opiates. We get your drug screens, blah, 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 no more than 30 days. So some sort of blurb has to be in your office, okay? This prescription drug monitoring program, this is key. Before you're writing, especially a new prescription for patients, you gotta check this. Are they doctor shopping? Are they telling you the truth? Very helpful. It's a really good prescription drug monitoring program here in Hawaii. It's very user-friendly, much better than the one in California. A couple caveats that the Department of Defense, anyone coming from the Department of Defense prescriptions are not on this. Anyone at a methadone clinic that's for substance abuse is also not on this list. And so we've made the state aware that this is the Narcotic Enforcement Division has to start getting this on board so we can all be in the same page, okay? You don't have to check it every time you write a prescription, but on some patients I do. But you just need to check it every now and then you're supposed to put it in your chart that you've done so. Though the statewide agency does, every time you check a patient, they log that in, so you could always rely on that as well if need be, for any medical issues. Okay, benzos and diazepines. How many of our patients who are on chronic opiates are also on chronic benzos? The majority of these patients, over 70%, have a concomitant access to disorder. They've got depression, they've got anxiety, they've got all these things going on, and they're on a benzo. The problem is that 30% of people who die from opiate overdose have benzodiazepines in the system, okay? So you have to be really judicious about the way we're prescribing these two medications together. My policy is if they need to be on benzo, I want to see it written by a psychiatrist, behavioral health professional, and not only the recommendation, but I want them to be writing that prescription as well, okay? Otherwise, if the patient just, well, I just need to take this for my nerves, well, I'm like, well, you're gonna have to choose one or the other. You can be on the benzo, you can be the opiate, but I can't put you on both. It's too dangerous, okay? And then if someone comes in for a first time and they need to refill, and they give you the song and dance, you're allowed to write up for a 7-day prescription of both a benzo and an opiate at the same time, okay? But after that, you gotta start doing some work and making sure they're telling the whole story. Okay, and Jared Radula, he's our Chief Narcotic Enforcement Division guy. He's super nice, and he just wants me here today to tell you he's not after us. He's after abusers, substance use disorder, okay? People work in the system, maybe people taking illicit drugs. So we're here to help him. And if you have patients who are doing fraudulent activity by altering their prescriptions, things like that, give them a call, let them know. They put them on a watch list. Okay, Dr. Wen really wanted me to spend a little time on how to wean patients off opiates. It's not that hard, but it does take work. At Kaiser, in 2.5 years, we were able to reduce our high opiate utilizers, and we had over 1,200 of them. We reduced it by 72%, okay? So we kind of came up with a formula that was very effective. Overall, we were able to reduce opiates across the board by about 28%, which was really good. That was really good. And what we called our movement the power of the pen. And what that means is that we empowered our primary care physicians and educated our primary care physicians how to be less lenient in writing for opiates. We empowered them, okay? And again, when we're telling our patients we're taking them down, we don't tell them, you're on too much, I don't like it. We tell them we're doing this for your safety, we're doing this for your health, which is really the reason we are doing it. There's several tools out there you can use to identify who tends to be patients more at risk for substance use disorder. I mean, to be honest with you, you could almost boil this down to just the question number 2. Do you have a personal history of substance abuse with either alcohol, illegal drugs, or prescription drugs? If they've got a remote history, then you have to be extra careful with these patients, okay? Very high prevalence of recidivism with substance use disorder, okay? So I put this on the chart for patients that I'm starting new therapy on, and it's quite helpful. There's other tools out there. This supervised, it's a little bit more long-winded, has some more functional questions added to it. But having this in your chart is a smart phrase you can fill out quickly. One of the other things I'm always looking for is if they have any adverse childhood experiences. If you're a patient who's had a history of emotional or physical abuse while they were a child or adolescent, very high correlation with substance use disorder and chemical coping. So that's one of the main questions we ask. So, going on and getting back to tapering, when we discharge patients from the OR, here's a novel idea. We should just discharge them on a tapering dose right off the get-go. I know it's hard to get surgeons to listen, to change the way they do things, but this is pretty easy to do, right? Otherwise, the patients, oh, we'll take 4 a day, here's your 60 tabs, and they call for a refill even though they don't need that many, and get a slippery slope. So this is one of the ways to prevent that. How to taper. There is a guideline up in the right-hand corner that you can download from the CDC. It's a little handout you can print, you can have it in your office. And it helps, it's not only for clinicians, it's for patients too, just describing what things work. I can tell you, you've got to go slow. I'm a parent of 3 children, and I can tell you, I used to think the bond between parenting and your kids was the strongest bond in the universe, but I was wrong. It's addiction. I am just shocked at how patients can't let go of their drugs, how they would rather let go of their children. It's just, it saddens me greatly. We're seeing what happens to these patients' lives and their family lives. So I get it. This is not easy to do, and they're deathly afraid. So you gotta go slow. We don't have great science, but on average 10% per week is pretty good. They can tolerate that. If they've been on it for 10 years, I slow it down to maybe every 2 to 4 weeks. Go slow. But they're gonna hurt more. They're gonna have a little more anxiety, right? Because they're so attached to these drugs. But don't go backwards. If you go backwards, they're gonna work you. And believe me, these people are professional BSers, all right? So you have to be extra careful. You have to encourage these patients. Again, let them know, look, it's gonna get a little worse, but overall, you're gonna get better. 90% of our patients on high doses felt better. So give them some hope. It goes a long way. And then you have to make sure these patients receive appropriate psychosocial support. Are they being followed by psychiatry? Are they being followed by a pain management group? Do they need cognitive behavioral therapy to work on a more effective way of reducing their pain as they're getting weaned down off these opiates? Withdrawal medications, there's a plethora, take your pick. I just fill this out according to what the patient's need are. If their chief complaint is they're feeling very restless, they're having tremors, can't sleep at night, then the tizanidine, the visceral work great. Nausea, the Reglan, diarrhea. Basically, these are all the opposites of what happens when you take opiates, right? Constipated, all the stuff. So this is just the opposite reaction. I just treat them accordingly. I don't use benzodiazepines as a withdrawal medication. Okay, I think that's just substituting one problem for another. And the clonidine is very helpful for the night sweats, and slightly helpful for the anxiety as well. What's going on at our emergency rooms? They are definitely on board. Up to 50% of patients who get involved with prescription opiates develop substance use disorder. This is where it started, in the emergency room. So the emergency rooms are stopping injectable opiates. Let's say for patients that come in with migraine headaches. They're writing very short prescriptions. They're not writing for long-acting prescriptions. When someone comes in saying, my dog ate it, and my neighbor stole it, that's not an excuse. You don't get a refill for that. It's their responsibility. They're also not writing for replacement doses of substance use disorders such as methadone and Suboxone in the ER, though I think we'll start using, there's at least one good study out there showing using Suboxone as an opiate for patients who come to the ER has less of a chance of developing their substance use disorder, so we'll see some changes there. But the bottom line is that the emergency room is on board here in Hawaii. So what's new? Okay, well, you've probably read a little bit about Suboxone in the lay literature. I don't know how much is being used here at this medical center, but it's a great drug. It's a great drug for a couple of reasons. First of all, it's only a partial agonist, so it just works to a certain point, and then it flattens out. It doesn't. You don't get more analgesia. You don't get more euphoria, which makes it good to use. The other thing is there's no risk of overdose and death. I mean, Suboxone is actually a Schedule III drug. I mean, you can phone this one in, right? It's very safe. It's even though it's only a partial agonist, in its opiate effect, it is a super strong agonist to the receptor. So whatever's lying around opiate-wise gets the big boot, gets kicked off. So it's a good drug to use. It's got great receptor affinity, but they can't take other opiates while they're on it, or they're going to have some withdrawal symptoms, okay? So good, safe drug to use. I think we'll start seeing more of this, especially in the substance use disorder clinics. It's going to replace methadone because it's much safer to use. It is also my drug of choice when I have a patient that has the diagnosis of chronic pain and substance use disorder. This is my go-to drug, okay? This nasal Narcan, we should all be prescribing this to our patients. I'm sure the geriatric population that you're a little bit more worried about metabolism issues and them becoming overdosed, cognitively impaired. This is absolutely a lifesaver. This is available here on the island now. And what it does is it gives you a few minutes of reversing the opiate effect while you call 911 and wait for the paramedics to arrive. It's not a long-acting treatment. When you administer this in one hand, you should be calling 911 in the other, okay? Because it's so short-acting. You can repeat it twice. It's really meant for patients and their families to have on hand, okay? Now, pharmacists here in Hawaii are allowed to prescribe this without a physician's prescription. The pharmacists have to get training to do this, and the majority of them don't have the training, but they will probably get it in 2019, okay? But we need a little bit more of population education that they can go to a pharmacist and get this and have it at home for their friends and family. Okay, so finishing up here, kind of working with pain management for the last 6-7 years, I wanted to go over what 4 things I think work the best for these patients. Number 1 is, again, using 2016 guidelines based out of the CDC, having responsible opiate prescribing practices, okay? I only give 28 to 30-day refills of medications, okay? Having a ceiling dose. For me, that's 100 morphine equivalent daily dose. Okay, I don't want to go over that. Now, there are patients who are high rapid metabolizers and isolated patients that may need higher, but that's my ceiling that I try to stay below for 95% of my patients. Maximum quantity of pills is 200. I may be lowering that to 140 so that they just don't have a lot of pills lying around. How do kids and adolescents get hooked on prescription drugs? Number 1 reason, they steal it from their parents' medicine cabinet. Urine drug screens and the prescription drug monitoring program. Again, you have to do this frequently. I know this is a geriatric population, but I can't tell you how many people in their 70s have problems with substance use disorder. You really have to be on your toes, okay? I have most of my patients come to my office for a refill in private practice, so I see them once a month. But for patients in the system, like when I work for Kaiser, they can fall through the cracks, but I have to make sure they're minimally seen at least twice a year, and that was required by the state of California. Pain consults, if you have a patient that's on high dose of opiate, get some help. Again, these are professional BSers. Don't try to handle it alone. Get some help out there, okay? These people work you over if they have substance use disorder. So ask for a consult. You don't have to send the patient there and have all the refills done, but just to get a consult, get some idea if you're doing the right thing, heading on the right track, get some information. There are certain drugs that I think should not be used because of their high addiction potentials of hydro and soma. And anyone who comes to my office on soma has substance use disorder until proven otherwise, okay? And mandatory opiate weaning for aberrant drug behaviors. I know, doctors, we're empathetic, we're nice people. I was a marshmallow when I came to running for prescription opiates way back when, but not anymore. We have to help these patients out. We're on their side, and we have to be safe. And if they break the laws, I may give them one benefit of the doubt, but if they continue to show substance use disorder, they have failed, not therapy, not treatment, not me, they just failed opiate therapy. That's all. It means we're moving on. Okay, focus on improving patient outcomes. We need more coverage here on the island for non-opiate treatment options, more physical therapy, Acupuncture is covered by Medicare in California. It's not covered by Medicare here. That's a big change we can make. Studies have shown that to be twice as effective for spinal pain than medications and injections. We need to have good access to chemical dependency programs. We need to have their numbers on file. We need to have their flyers ready to hand out to our patients, because when they failed opiate therapy, they have substance use disorder, this is who needs treatment. It shouldn't be us pain management doctors or internists in primary care really treating addiction patients unless you're an addictionologist. They really need to be treated by professionals, so there's more resources there to help these patients. Okay, and I'm also a big believer in providing RN case managers for the high utilizing chronic pain patients. They use a huge amount of resources, and these are patients we're not curing. These are patients we're corralling, okay? And a nurse case manager can be very helpful for that. There was one other thing I wanted to bring up, is that, maybe I have another slide, yeah, here it is. If you're getting urine drug screens on your speed dial, you need to have the lab tech from the company that does your urine drug screens on speed dial, because these are hard to interpret. There's a lot of metabolites from these opiate urine drug screens. And so to have someone to call to help you interpret these, because you're accusing patients of breaking the rules, and you want to make sure you've got confirmatory testing that it's not an expected metabolite. Like if you get enough morphine in your system, it'll show up as codeine. All right, so you just have to be aware of these things. So the hotline, I call them all the week. They know me by first name, believe me. Identify health plan, prescribing physician. So what we did in big health plans is usually you can find a couple of physician providers who are over-prescribing way more than everybody else. We bring them into the principal's office and we have a talk. Just making sure we're all on the same line. Same with patients. If there's patients that have outlier medication prescribing identified by a health plan or a pharmacy, these are patients we need to sit down and have a conversation and see how we can find other ways to manage their pain. Naloxone promotion, again, something we should be doing. And then lastly, the multidisciplinary treatment approach for handling of the opiate epidemic as well as chronic pain is instrumental. We really don't have that set up here on this island. We really need to have more multimodal, interdisciplinary pain programs that we can induct patients in, so that they can have pain management with pain physicians, pain case managers, pain physical therapists, pain psychologists and pharmacists, etc. Because again, these are very complicated patients with multiple comorbidities. Multidisciplinary pain rounds, I don't know if you guys have anything, but it would be similar to like an ECHO program that Dr. Wen has going, where you can pull up a case, talk to all the physicians involved, the internist, the psychiatrist, the ER doc, and the pain doctors. We can all have one set plan for this patient, have it put in the patient's charts, we can all stick to it together. Okay? Pain management phone line. What I've done at Castle Hospital at work now, I said, look, you got any question? Just call me. You don't always have to send me the patient. Maybe it's just a quick question. Here's my phone number. Call me night or day. I'll see if I can help. And then co-treat with primary care physicians. You know, if a patient is just on 1 or 2 Vicodin a day, they really don't need to be followed by me if they're stable. But I'm there to help co-treat. Okay, so maybe send them to me. We'll come up with a plan. Send them back to primary care. I'll see them a couple times a year. If there's questions, problems, give me a buzz. Okay, but it's co-treatment of these patients. Last few slides, just wanted to point, this came out JAMA, March of 2018, showing that for musculoskeletal complaints, chronic low back pain, hip, lower extremity osteoarthropathy, morphine's no more effective than using Tylenol or NSAIDs, and I understand in the geriatric population, and you guys are really good at this. I'm just assuming anyone over the age of 65 has a little bit of renal insufficiency. It's kind of a gimme, right? So I'm very cautious about the use of NSAIDs, as well as the GI bleeding things. So I tend to use a little more Tylenol and other things. But the opiate, you have to be very careful, because it doesn't work that good. It certainly doesn't work any better. And then lastly, we brought this up at one of our ECHO meetings before, is the patients are starting to ask a lot about cannabis use. I was just in San Diego last week, and it made me realize a couple things. First of all, there's no billboards up on the freeways here in Hawaii, which is quite nice. I can tell you half the billboards in San Diego are about marijuana. because they just legalized it last year for recreational use. It's just crazy. And then we saw these buses, these big, huge party buses, these limo buses, loaded with people with this big marijuana plant on the side. And they were taking these people to these dispensaries, and then they're partying, and it drops them off at home. Like, that looks like fun. Anyway, we're going to start seeing more of this, because the medical use of marijuana, as you can see by this Cochrane database, really hasn't been shown to be efficacious. Just for the use of neuropathic pain, maybe a 4% increase. There was a big study done, the European Pain Society. They found no benefit with the use of marijuana, yet we're all talking about it for its medicinal qualities for pain. So it's clearly a case of really justification to really legalize marijuana recreationally, where this whole movement started. Is it helpful for some patients? Well, we think the CBD part seems to be helpful, not the THC. I know in California, 90% of the medical card prescriptions for marijuana were high THC and low CBD. We're starting to see that change a little bit, especially here on the island. We're seeing a lot of people using the CBD oils, which are non-prescription if they come from the hemp plant. And some of my patients, rub a salve on their knee and they do feel a little better. So I think in stride, but the jury is still out about its true medical efficacy. So if we can push the CBD, low THC, and using it sparingly as an adjunctive treatment, then I think there's a reason. In my personal clinical practice, I find the utilization mostly for people who have central nervous system problems, such as multiple sclerosis, spinal cord injury, brain injury, and stroke. Tends to work the best for them from my clinical experience. And lastly, this would be the bottom line. When you're starting to write opiates for a patient, just make sure the benefit outweighs the risk. Okay? And with that, I'll say thank you and take any of your questions. I know, Ada, they don't ask a lot of questions after these talks. I always go home thinking, I either did a good job or I bored them to death. I don't know which. Any clinical vignettes? Some difficult patients. Yeah.
Could you kind of go into a little bit more about what you do when you prescribe the Suboxone for chronic pain? Like, what does that follow-up for patients usually look like for you?
Yeah, so it's pretty easy. Now, they have to be off all their other opiates for a minimum of 24 to 48 hours. So I said, well, look, you got to get off whatever you're on first. Once they're off for 24 hours, I write them for a prescription, and it comes in 2, 4, and 8 milligrams. It's either a tablet or a film. I think the tablet's a little less expensive compared to the film, and your insurance company might have something to say about that. I usually start them on the 2/0.5 milligram tablet twice a day to 3 times a day. That's a good starting dose. The maximal dose is 24 milligrams a day. That's for usually a person with pretty significant substance use disorder that you're using it for. If they're failing treatment at 2-3 times a day, I'll go to the 4 milligram 3 times a day. You'll notice that it's 2/0.5, which is the naltrexone in it. That 0.5 is so low, it really doesn't precipitate withdrawal. The only thing that naltrexone in that preparation does, it keeps them from melting it and putting a syringe and injecting it in themselves. So that's the only reason it's mixed that way. Okay, the reason they have withdrawal is just because of the affinity for the drug, for the mu receptor. Did that answer your question?
Yeah, so do you do like inductions in your office, or do you have them go home?
You know what? I know. I don't do inductions in my office. I actually just have them do it at home. Yeah. I think a lot of the inductions were done for substance use disorder, higher doses, and for pain, I find it pretty easy. Because you can write for a buprenorphine patch, right, and just do that at home. So that's not something that I've done in my practice customarily. For patients who are going to the hospital, let's say having a procedure, you most likely want to get them off the Suboxone because they're probably going to use shorter acting opiates, but not necessarily. Again, it's a very strong receptor. If you give, it's how you time it. If you give them the Suboxone and then wait 2 hours and give them short acting, that gets them added analgesia without the withdrawal. So that's something you can tell your anesthesia brethren. questions, I'm free for a few more minutes. Come on up. Thank you so much for listening. I really appreciate it.